Right, they're here, both of them. We're going to talk about something you don't know about, never heard about. We're going to talk about the PUL. The PUL system. I'm sure you've never heard of it, but it's going to be even better because we're going to hear about the PUL by Callabe. But now Callabe has a young doctor with him. He's going to speak with him. Dr Tebourbi is going to be the second speaker. And so they are going to show you how you can mix the PUL with the Genius system. The floor is yours. Thank you. There we go. Thank you, Ephraim, for this very nice and kind introduction. First, I would like to thank Charlie because it's an honor and a pleasure to talk before you here. I'm going to talk about a topic I'm passionate about, treatment of Class 2 with PUL and Genius system. For those of you who are not familiar with this device, this is what we are talking about. First, I'm going to introduce myself. I have a private practice in Nice with my beautiful wife sitting here in the public. I discovered that device a few years ago when I took the class by Callabe, and when I discovered that device, I completely changed the way I treat a Class 2, and I'm a lot more serene. And also I use that beautiful system that we all know, the Genius system. Dr. Koleila yesterday talked about the Genius system, the bracket of course, but also the wires, and we shall see that when I show you the cases. I'm going to introduce you to 5 clinical cases just to illustrate the topic, correction of Class 2 with PUL and Class 2. We're going to start with Noé, 12 and a half. We're going to show you first the extraoral photographs. You see that he has a Class 2 profile with a typical retruded chin. This is the side teleradiograph. Skeletal Class 2 with a retruded mandible. This is the pan X-ray before radiograph, and those are the intraoral pictures. The PUL is very interesting in asymmetric cases. This device can be activated either side or both sides at the same time. So this is a Class 2, so full Class 2 on the right, Class 1 on the left, a very severe deep bite, and the midlines, of course, are deviated. The PUL was placed in June 2019, and that was a first-line treatment. In Class 1 Division 1, you treat as a first line with a PUL. This is not always the case. Now, this device is going to be worn for a full year, 1 year, 2 phases. One phase during which we collect the skeletal difference, and then we shall bond the brackets, and this is the second phase. We're going to see the patients every second month. So every 8 months they come in and we activate the device. We're going to tell you more about the activation protocol in a moment. About 1 millimeter of correction per month is obtained. So 3 turns of the key, so about 1 millimeter per month. And this is what we get 1 month later. 1 year later. So Class 1 on both sides is obtained, the deep bite is corrected, and the midlines are aligned. Now, all this to say that I saw that patient 6 times in my chair, 5 to 10 minutes for each appointment, so it's very comfortable, and in a very short time you can correct very comfortably those types of malocclusions. This is profile before and after, with the repositioning of the chin and the better balance in the overall profile. Those are the photographs before treatment, during the PUL phase, and after the PUL phase. And look at this deep bite correction, very nice and impressive. Now, with this protocol, straight away we bond the Genius system. Now I shall show you a summary at the end of each case. I bond from 6-6 and I start with a 0-14, then 0-18 from 7-7, and then my reference and final wire is a 20x20 thermal ultra. Very important. Those ramps are very important. In my practice we call them the propulsion ramps. Why do we call them propulsion ramps? Well, it's because they are slightly active. They are bonded on the palatal side of the canines, and they are slightly slanted. There's a slope. So they are slanted, therefore they are slightly active, and so they provide an extra propulsion in the mandible. And I also have a patient where 4 ounces elastics, those are the kite surf by all 4 partners, because they're really going to help with intercuspidation. This is the finished case. Class 1 on both sides, deep bite is corrected, and the midlines are nicely aligned. Those are the side radiographs, and this is at the end of treatment. As you can see, the mandible has repositioned itself nicely, but we also respected the axis of the mandible excisor. Now the profile is nicely balanced at the end of treatment. This is the patient's smile at the end of treatment, and this is a short summary of what we did. I started with the PUL device. It was worn for 1 year. As I said, activation every 2nd month, so you can schedule an appointment every 8 to 10 weeks. Before I bond, I do new photographs, radiographs, and I bond those ramps that I talked to you about. So I do that before I bond the brackets, and I burr the device resin so as to let them fit over the ramps. I bond the upper arch first, and 1 week later I bond the lower arch. I don't wait a very long time in between both bonding sessions, because I really need those elastics to be wound as well. 6-6, 7-7, 20-20, and 20-20 is the time for my intermediate review. I do a pan X-ray repositioning. I repositioned those 2 brackets. Yesterday, Dr. Callabe talked about the genius system and said that the slot was very accurate and that the wires are very high performance. Now, something else I like very much about that bracket is the internal part of the bracket. It fits very well on the teeth, and I like that very much, because when I debond, I sand the bracket and I reposition the same bracket, and it doesn't budge. Now, those are the wire sequence, and it lasted for 30 months in total. Second patient, her name is Telia, she's 14 and a half, and you're going to see that the PUL system works very well in teenagers as well. This is a side radiograph, class 2, skeletal class 2, retruded cheek, and you see that she's already at the CS3, CS4 growth stage according to Bacchetti, which means that the window is about to close. We don't have much time. So this is a class 2 div 2, asymmetric, more class 2 on the left hand side, and you have the 11 and 21 which are locked, and you also have a lot of crowding from the canines to canine, from canine to canine. Before the previous case, we used the PUL in first line, and you need to remove that interlocked canines in order to be able for this mandible to move forward. Now, what's very important is to have this interincisor guidance. You need to have interincisors at contact so as to avoid the lower lip to be stuck in between the teeth. I think it's very important when you have such a class 2. So I have this partial device from 4 to 4 with 0-14, a thermal ultra, works very quickly. That's important. That PUL device, those of you who are familiar with it, you know that you don't have any resin, any plastic on the occlusal side of the posterior teeth. You see here that the metal part is right before 6, but it could be before number 4 or before number 5. So your device is not a one-fit-all device. The device is customized according to your patient situation. Because you have a disocclusion, the posterior teeth are going to extrude, and it's really going to help deal with that class 2. This is 1 year after. Class 1 on both sides, deep bite is corrected, and obviously you see that number 25, which was slightly lagging behind, is now in the arch. When you bond those partial brackets, I recommend to cut distally from laterals so that the canines can move back and find their place in class 1. This is the side photograph. You see that the chin is now more advanced, and it's very nice. A and B, 4, 7, and you have your incisors, the axis of your incisors has almost not changed. Again, we bonded those ramps, those propulsion ramps. Every time I have the possibility to bond those ramps, I always have them. You can also bond them on the premolars if you can't bond them on the canines. Now 0.18 thermal ultra from 7 to 7 after 6.6 in 0.14. Now I'm going to have the 2 ounces elastic basketball. Those are shorters in between the incisors, in between the lateral, and I know that I'm off to a good start. Now we are going to focus on those ramps. So they are slightly slanted, as I said, and the mandible canine is going to press on those ramps, and of course you shouldn't have any contact between the premolars and the ramps. So no contact, but you need to check as the treatment progresses. You shouldn't have any contact here between those ramps and the premolars. It's only for the canines to touch upon them. So we continue treatment, 7 to 7 thermal ultra. I systematically bond on the 7th, and again elastics, 4 ounces, one in a triangle, to really help that canine find its place in a class 1. This is a finished case. Class 1 on both sides, aligned midlines, and the deep bite is corrected. Now the profile before treatment, at the end of treatment with PUL, and at the end of the genius system phase. This is the patient's smile. Now, a summary of what we did is slightly different from the first case. We started with that premolar to premolar bonding 3 months later because, again, time is of the essence. You shouldn't wait too long. Digital scan. We ordered a PUL. We had it worn for 1 year, activation every 2nd month, butt ramps are bonded, and then we always unfold the same protocol intermediate review after 2020. My reference wire is 20 by 20. Dr. Callabe yesterday said that he has a 19 by 25. I like it because you have 6 degrees of torque play in a 22 by 28, although it's 21.5 by 20.5, but never mind. So little torque play, only 6 degrees, so I like it very much. I debonded and rebonded 3 brackets, and in total the treatment lasted for 29 months. Now Simon, a teenager case again. Now it has to be said that when your patient comes in, of course you see the patient, you do the examination, and also you explain what you're going to do to those parents. Of course, you need to have a comprehensive approach. You're not going to deliver them a PUL and say, well, goodbye, I shall see you in 2 months. You need to provide explanations. You provide them with instruction sheets. You show them before and after pictures so as to get them very motivated. But we're very successful with this device, but it has to be prescribed properly. Now, those are the SF intraoral pictures, class 2, div 2, both sides, and you have number 11, which is completely locked. It's impossible to have the mandible move forward if this incisor is not proclined. So I start to bond between 3 and 3. Then between the 6 I have the arm and also have the hook. Now, about the hook. This device doesn't really fit or doesn't really click on the teeth. You help with tongue rehabilitation because the tongue has to really place the device to the palate, and so it really helps with tongue rehabilitation. So when you provide the device, you are going to work on those hooks just so that the device doesn't fall from the mouth, because the poor teenager or the poor child can't swallow very nicely, can't talk, so you just help them by strengthening those hooks. You're going to loosen them in a couple of weeks. Now this is the case, and once again, you know, you only saw that teenager 6 times. 6 visits, 10 to 15 minutes. We show them the pictures before, how they look like before, and you see them for about 15 minutes, you activate the device, you double check that everything's just fine, and so it's very comfortable, and it really helps you treat those types of malocclusions very nicely. This is the side photograph before. You see that the lower third is now a lot more balanced. So this is the side radiograph before and after, and you see that the mandible, the lower arch incisors, the axis is not changed. Now from 7 to 7, and again those ramps that we use to really help with propulsion. 20 by 20, intercuspidation with elastics. We have in 19 by 25 beta titanium. I had the ceramic bracket here, so I didn't want to use a stainless steel wire. Then it's stainless steel on the lower arch, and this is the finished case. Class 1, deep bite is corrected, and midlines are very nicely aligned. Side radiographs, you do see that the lower arch incisor axis is nicely corrected. At the end of treatment, we had to do some bends, some insets, because you're not going to correct that with torque. And those are the only finishings I did, and the only bangs. So bends on the incisors, inset on the incisors to help them get perfectly in their axis. So this is before and after treatment photographs, the intraoral photographs before and after respectively. Now, a summary of what we did for that patient: partial bonding, digital scan, PUL is ordered, one for about 1 year, and the different activations and wire sequences. Mathilda. So we saw 2 cases of 2-2, 2 subdivision, and this is another case here with subdivision 1. Extraoral photographs. A profile with a slightly retruded chin, narrow smile, pan X-ray, side radiograph. The incisor is slightly proclined. Class 2 canine molar, both sides, deep bite, and as we said, the maxillary incisor are slightly proclined. Once again, we started first-line treatment with PUL, and it helps with better balance from a skeletal point of view. Now this is after 1 year, class 2 is corrected. Now this canine, of course, there's this slight diastema, and so that canine needs to be better corrected. Ceph X-ray. And again, what's very important is the axis of the incisors in the lower arch. This is the profile after that PUL phase, intraoral photographs at the end of this PUL phase. And then we go on with the second step or second phase, those ramps. It's very systematic, as you can tell. There's a protocol and a logic to this. So ramps, we use intermaxillary elastics. I bond from 6 to 6. 014, 014, then 018, 7 to 7, upper and lower, intermediate review, we control the axis, we check that there are no rotations or maybe some brackets that would need to be repositioned. 41 and 44 were repositioned, thermal ultra with short elastics, intermaxillary occlusions, again to help with that canine so that it finds its place in class 1. 1925 stainless steel, upper arch. This is when we start the finishings. The incisors in the lower arch are slightly retruded. We close the space. Pan X-ray at the end of treatment. You compare the side radiograph A and B from 6.4 to 3.6, and the incisors in the mandible hasn't really changed at the beginning of treatment and at the end. This is the finished case. Class 2 photographs after treatment and the comparison. The smile of this patient. Profile is a lot more balanced. And this brings me again to focusing on those ramps. You can remove them at the end of treatment, but sometimes we scan to have the retention splint manufactured, and sometimes I remove the ramps afterwards because it may help with extra stabilization during the retention phase. I shall conclude with that case. Those photographs, that patient already had been treated for 3 years. So she came into my practice with that. Father tells me, well, she's been in treatment for 3 years. Do you think that the treatment is about to be completed? What can I tell the poor man? Only that, no, the end is not in sight at all, very far from it. And that's difficult. She's 14. His brother was treated for 4 years. I have not included the photographs, but it's even worse. So 3 years of treatment under her belt already, and so we need to be quick, or at least provide her with a concrete solution and really motivate that patient. Now, she's motivated. She does accept the device and the treatment plan. Those are the extraoral photographs. Look at the very severe gingivitis that she has. And her profile is typical of a class 2. This is the side radiograph before we treat her. You see that the incisors are retroclined because power chains were used with round wire. Look at what it looks like in her mouth. Now, the first thing I do is debond everything, and I give her a prescription for gingivitis. I see her 4 months later. 4 months later, the gum look a lot more healthy. Now, what do? Should we bond brackets again, hoping that we're going to compensate for this full class 2 only with bracket and wires? Shall I tell the patient, well, maybe she's going to need surgery? The nice thing is, I have this beautiful tool in my toolbox, and I explain to the dad that we're not going to correct the class 2, but we're going to try and compensate the difference between the upper and lower arch. And the father is very confident and trusts me, and this is what we get 1 year later. You'll notice that the tongue, of course, is not positioned properly. We had, say, a physiotherapist. We did everything we could. Physiotherapy, PUL, all options were used. Now, this is her profile. You see that the mandible has positioned itself. And this is the side radiograph before we started and after the PUL phase. You see that the mandible is nicely positioned. You see that there's a better access to the upper incisors, and the lower incisors are not tilted to the tongue, so they are retroclined, slightly retroclined. Now, in that case, it was not possible for me to bond ramps because there's just not enough intercuspidation in this patient. So when I have no choice, I don't bond ramps. However, I used intercuspidation elastics as early as possible. I bonded from 6 to 6 and I started with 0.18 from day one. I very rarely did that, but I really rarely do that, but I had no choice with her. We wanted to be as quick as we could. Then 7 to 7, 20 by 20 elastics. She was very compliant, a very nice patient. Everything I asked her to do, she did. And I didn't explain, but on the right hand side we also had a crossbite, and this is also why we have this crossbite elastics on the right hand side. So the case is still ongoing. And this is what we ask. The crossbite is corrected on the right hand side, midlines are aligned. We have a very nice intercuspidation on the left hand side. It's not finished. We still have the lower arch incisors that are proclined. The case is far from being finished, but I think it's stable. And we are going to finish her nicely. So this is when she came in, and this is at the end of the PUL phase. Now, maybe I'll have the opportunity to show you the finished case, maybe next year, but this is still an ongoing case. Before I wrap up, no, I'm not going to wrap up. I still have a few slides that I'd like to show you. This is the PUL device, for those of you who are not familiar. This is this patient on her second appointment. Look at how easy it is for her to put it in her mouth and remove it. Very easy. I shall conclude, as I said, with those photographs. This is an ongoing case. I saw this patient, so class 2, skeletal class 2, very severe regionetic profile. The profile is very impacted. I have a wear that PUL. Only 6 months in between the photograph on the left and the photograph on the right. It only took 6 months to go from here to there. Intraoral photographs are included as well. So when I see something like that, it's really a source of motivation. It really motivates me to continue and use that protocol. And look at the posture. 6 months into treatment, her profile is corrected, her posture is changed, airways are larger. So with that protocol, we correct the class 2, but also we try to be as respectful as possible to the TMJ. We start the tongue rehabilitation as early as possible. It started with the PUL because the part in the maxilla doesn't fit nicely on the tongue. It's on purpose so that they have to stick their tongue to the palate. So it's a very comprehensive, holistic approach of this class 2 syndrome, as we call it. And after that, you start with a genius system. I was introduced to the genius system straight away. I started with that system in my practice, and of course we talked about the accuracy of the bracket. The Y is very powerful, and again, as I said, I really love the inside part. What we don't want are emergencies in the practice, and I don't have that many because those brackets bond very nicely on the teeth and they hold very nicely as well. Now, all those cases, we also saw cases yesterday by Dr. Pujol. He showed us how he corrects class 2 with DADs. Our colleague showed us how she uses the Danfair appliance, and I found it very interesting, by the way. So all those cases can be treated exactly the way you want. This is the protocol that I like. It helps me be very serene and helps me to provide very comfortable treatments to my patient. And so I would like to thank you for your attention, and I hand it over to our colleague, Dr. Callabe. Thank you. It was his first presentation at an international congress, so I think he's very deserving of a very warm round of applause, because champs, I also get stage fright. It's been 22 years but I've been a speaker and I still have stage fright. And I'm sure that all the speakers that spoke before us had some as well. But it's a good form of stress and it's a good source of motivation. Now, you could see how a young orthodontist, maybe 10 years experience under his belt only, but you can see how our fellow doctor, by using quality product, gets the result that he gets. What makes a good orthodontist? What makes a good professional compared with an average professional? Whether you're a plumber, an electrician, an orthodontist, what makes the difference? Well, the tools that they have in their toolbox. And the second parameter are the years of experience. So the more tools you have in your armamentarium, the best equipped you are to pick and choose the right tool. Each patient is unique, and so we need many tools. And so I'd like to thank the speakers this morning, but also yesterday, because they gave us new ideas, new tools that we can add in our toolbox to better treat operations. I have a private practice for 37 years in Blois, on Ile Blois. What's the drawback of being an orthodontist for 37 years is that you get to see your relapse cases. And if you don't want to see your relapse cases, what should you do? You should move every 10 years, right? That way you don't see them. Now, I didn't do that. And you've seen that device. Why? Why did I design that? The first objective of this device is to help with cooperation. You usually have 30% cooperation with conventional activation devices, and we close to 80%. Why is that? Because it's very small. We use laser welding, and it works very comfortably and very nicely. And we have a family of PUL devices now, which are well adapted to all type of faces. And I have to say, I've had 2 lives already. Between 1987 and 1997, I only treated my patients without PUL. That was my first life, and then started my second professional life. In 2001, I presented the PUL. Since then, we have more babies in the family. Started with PUL 1. Cham presented you on new device with one single propulsion part, PUL 2, PUL 3, PUL 20, PUL Snorlight, the entire family. And it all started with a patient asking me to weld both Herbst's devices together and to create a single contraption. It all started with that. The advantage of younger doctors, if they've not been through the war and they've not experienced orthodontics without a PUL. PUL changed my life. This is a colleague of ours. Now, even when I have a class 2 Div 2, I know that I can correct this retruded chin, and I know that I'm going to get a beautiful class 1. I have happy parents, and I provide a very nice result to a kid, and the kid finishes his or her treatment with a broad, nice smile. It's life-changing, and this is also why the PUL is life-changing is now the motto of our club, the club of PUL users. It changes our life as doctors, but it also changes our patient's life. We correct a class 2 in a class 1, it changes a complex case in a simpler case, and it's really life-changing. Now, someone famous said, those who do not want to imitate anything produce nothing. He's not a doctor, but he could have been a doctor. It's Salvador Dali. And of course, I was inspired by existing devices, the Tavernier device and the Herbst device, which I merged together. Basically, what I did is exactly what Steve Jobs did. Of course, I'm not comparing myself to Steve Jobs, but what he did was take a camera, a phone plus an internet device, and he created the iPhone. What I did is take the Tavernier device that here. Help, the remote control doesn't want to comply. Oh, right. So I took that central device, per Tavernier, then the lateral device that Herps invented, and I created the swift knife of orthodontics, the PUL. It's just smaller, and it's a new propulsion device with a coil. So it's light, comfortable, it respects the physiology, it's very aesthetic, so as to be worn at school. What's a functional device? A functional device helps the child function day and night, so it should be worn during the day and also during the night. And compared with the Herbst of Tavernier, you can have it worn on decidual teeth that are going to exfoliate, and the tooth exfoliation is not going to prevent the child from wearing the device. It's going to work on all aspects, chewing, swallowing. On the teeth, it has a homeopathic effect as well. It's going to help with distalization, it's going to help with mandibular growth, etc. So in the PUL family, as I told you, there are three very innovative devices. PUL 2, which was presented to you, but also PUL 3 for functional class 3, and PUL W, retention device, is the device that we prescribe to our teenager patient in order to reduce the percentage of relapses from maybe 1/3 of them relapsing to a couple of % only. So the main asset of this device is that it's small and also is very respectful of the anatomy, especially of the MJ. The forces are not placed on the device itself, so it can be worn for 12, 24, 36 months, maybe longer. I also have a device which helps with snoring, the anti-snoring effect, and it can be worn for many, many years. And that's an added benefit. So this is not an ultra propulsion device, it's a very respectful device which respects the temporomandibular joint. And the difference is that, of course, we do not cover the occlusal part. So we have that soft propulsion the patient gets in class 1, and we respect the TMJ and the muscles as well. This concept is very interesting for class 2s. About 70% of our patient base, mostly low angle, but also high angle. We have more high angle patients now than we had in the past. I made a presentation some time ago at a conference in Bucharest, and a friend of mine, well-known orthodontist with 50 years experience, and he told me, well, Ali, say you have a full class 2, you haven't worn your device here, and after 6 months they're in class 1? And I thought, well, yeah, but I didn't understand why he did not understand my presentation. But I tried to place myself in his shoes, and I tried to think how I was thinking maybe 20 years ago, when I was less experienced, and of course I would not have understood. And the PUL device has nothing to do with magic, it's only common sense. How come you have a class 2, severe class 2 like this one, and 6 months later, after they worn the PUL, they're like that? Is it magic? No, it's not magic, it's common sense. How come this mandible is locked? Well, first, the lip and the occlusal forces. So what we do, we're going to prescribe a device which is going to remove that interposition of the lip, and it's going to prevent those muscles from acting. If you have a propulsion in your mandible, it's impossible for you to have a contraction in your masseter muscles. So you just neutralize those 80 kilograms of forces on your molar. 80 kilograms is almost my weight. I weigh 78 kilograms. It's just me standing or sitting on your molar. 22 hours out of 24, you remove that 78 kilograms or 80 kilograms of weight on your molar, and that's what explains the whole thing. That's what we call the Aikido effect. What's Aikido? You take, well, a muscle is designed to work in a certain way. For example, a masseter muscle is designed to work in a direction. If you change the direction, they just can't work anymore. So what happened here? The mandible, when it's not treated, is going to grow in the opposite direction to which it is locked. So what we do, we removed the 80 kilograms per square centimeter on the molar. The molar now can extrude. We level the curve of spay. The deep bite is corrected, and the incisors are now more straight. Why is that? Because the device has no occlusal part, there's no resin over those incisors, and so they can go wherever they please. And this is the Aikido effect. Does someone do Aikido here? So that we can train. So you just change the direction of the muscle and you neutralize. If you do that, you can contract the muscle. But if you prevent it from contracting that way, well, they can't do anything. That's what we do. That's the beauty of my PUL device. Now, Aikido, when you bond those rams, those back rams, this is exactly the same concept that Damon uses. This is the Aikido effect. The temporal and masseter muscles are just neutralized, and this is exactly what the bite rams plus elastics do with Damon, and this is what we get with the PUL. Now, in the high mandibular angle cases, how come we start from a situation like that to a situation like that? Now this is the judo effect. So high mandibular angle, what we don't want, we do not want the mandible to move to the front. So we want this mandible to be free and grow in a better way. And so what we do is, well, please, Madam Mandible, can you please grow, but grow in the upper part and at the front. And what's going to help the mandible grow in the right direction? Well, the temporal and masseter muscles. Now, with that PUL device, 22 hours out of 24, it's going to help the patient use their nose to breathe and swallow properly and put the tongue at the palate. It's going to help with molar extrusion. It's going to correct the deep bite, and the tongue is properly positioned, stuck at the palate, and it's no longer going to be stuck in between both arches. And that's the beauty of it. So if we were to summarize, for the high mandibular angle patients, we start from a situation like that. We use that PUL device before we use bracket and wires. So this is before, and this is what we get. And so at the end of that phase, when you look at those radiographs, you need to be very experienced to tell me, well, this patient used to be a low mandibular angle and this one was a high mandibular angle. At the end, it looked just the same. Those patients used to have a condition. What we help them with, we help them be more balanced so that they become more meso-angle. What's interesting here, look below the molar apexes. We created basal bone in the high mandibular angle and also in the low mandibular angle patient. Look at this. Here there was a posterior rotation. And what did we do? We did an anterior rotation. What did we do? We stimulated the masseter and temporal muscles, And when you have muscles and muscles working, you have bone. And of course, we also corrected the deep bite in the low mandibular angle case. This is a study by Dr. Sophie Pierre, and I do encourage you to read it. 34 patients, aged from 7 to 13. And what did she find? She found that when you treat those, you have the mandible body, it's going to be lengthened from, on average, 3.57 millimeter. Some patients even had as much as 6 millimeter of lengthening of the mandible body. And it's very important. We know that between 7 and 13, you can get close to 4 millimeters. A few years ago, I fell in love with Delaire software, and it's now something that I systematically use in my practice. And Delaire says that you have different types of bone creation potential in our patients. We live in a world where everybody speaks about big data, data mining, data management. We need data as well to treat our patients in the best possible way. You saw that our colleague treats many teenagers, and it so happens that the PUL device is very well suited to our teenage patients. How come it works so nicely in teenagers? Because we have an upper arch distalization thanks to a good anchorage in the mandible. If we look at conventional activation devices, all the devices out there that we know that fit on all upper teeth and on all lower teeth. When you get the mandible to move forward, what the mandible wants to do is go back to its original position. So if you have a 6 millimeter proportion, you have about 600 grams of force trying to get that mandible back. So if we want those molars to distalize, you just remove the anchorage here at the level of the incisors and the bicuspids. And that's what we get with the PUL. That way, the upper teeth are going to become distalized. And the more the mandible is going to be moved backwards, the more the molars are going to be distalized. So we use the problem as part of the solution. And one day I was in Norway in 2018, and I explained that to the participants. I saw both teams playing tug of war. You know, they pull at opposite ends of a rope. And on one side of the rope you have team mandible, and on the opposite end you have team maxilla. And this is exactly what we do with a PUL in our teenage patient. This is exactly what we do. We do tug of war. We just neutralize one of those teams, and the teeth in the mandible do not move. Only the teeth in the upper arch have become more distalized. If I have a 6 millimeter class 2, I do not want to do extraction, I do not want to go for surgery, I'm going to have 3/3, 1/3 of expansion in the mandible, distalization of posterior, and 1/3 is going to be obtained with a mandible advancement, which is more reasonable. Now, this is what we have. Is it judo or aikido that we need? We need the aikido effect, of course. We neutralize the occlusal forces. Those teeth can move freely, and so we're going to get a distalization of the posterior segment. And so, again, that's just common sense. There's no magic here. Also, we get a correction of a D-bite because the molars are extruded, the spear curve is being leveled, and we have a rotation in the molars. Look at this D-bite. We start with 0.14. The lower incisor is going to be procline. Of course, we're not going to get that with the Genius system because it's a passive self-ligating system and we control the torque very nicely. You see that we can remove that D-bite and you do not have a deleterious procrastination effect on the incisors or flaring. Now, it doesn't matter at what age your patient starts. If the patient is a young patient with a mixed dentition, doesn't really matter. You can start in mixed dentition, and they can start with deciduous teeth, and then those deciduous teeth are going to exfoliate, and they don't need to come back. We do not need to change the device. We do not need to correct the device. This is what I had to do in the past. There's no waste. The same device is being worn from beginning to the end. This is a study which is also very interesting, and it says that the device provides an interesting growth, harmonization of sagittal direction, and a very good management of the vertical direction, which makes it a good indication for dolichofacial patients. It was a first, that study in 2009, which confirmed that our device was indicated for dolichofacial patients, which makes up about 1/3 of our patient base today. I also conducted a study. I have about 80% of compliance rate, only 30% for twin blocks. And this is the range of ages of my patients in my patient base wearing a PUL. Most of them, as you can see, is between 11 and 13 or 15, 16. This is really the window where you want to optimize growth. So the first phase, you balance those skeletal bases, then you have the active phase, and then you have a stabilization. We're not talking about a treatment in 2 steps. We talk about 1 phase and 3 stages. And I think that the most important stage is certainly the anti-relapse phase, because we do not want that patient to come back maybe 5 years or 10 years down the line. So we help them until the finish their growth. And so this is what we give them. This is the finishing and retention device. And we're also very fortunate that we have the best reimbursement system in the world. 2 semesters for that, 4 semesters for that, and 2 years for that phase. This is the best reimbursement system in the world, and I pray to the gods that it remains like that, because our patients have a very nice reimbursement. Now, look at that patient, how they can insert their device. I show those videos. They are available on my website, PUL Concept. I do invite you to show that to your patients. We just tell them, look, what you're going to get, it's not bonded to your teeth. You can pull it in and out very easily. If you yawn, it's going to fall, because your tongue really has to maintain it to your palate. So it works very nicely. And this is the anti-relapse retention. Same thing. So you do not have 2 separate jigs. Both jigs are connected because it's going to maintain the transversal, sagittal and vertical direction. You prevent snoring, you prevent sleep apnea, and you prevent a tongue ptosis. So the tongue is not going to fall down and remain at the palate. If you look at adults, when you treat class 2 div 1 high angle or low angle, when they go for surgery, what will the surgeon do? The surgeon will work on the mandible. They're not going to operate on the upper arch. The condition that we have to deal with here is a condition in the mandible. And this is really on the mandible that we need to act. Those are surgeries before and after by a maxillofacial surgeon. The angle between the nose and the upper arch is the right one, so what we change is only the mandible. And so in a child, what we do, we act on the mandible. Those are patients that we treated with our concept. Just imagine if we had impacted the upper arch, that profile would have been worse. Just imagine what it would have looked like if we impacted the maxilla. So the condition that we treat is a condition in the mandible. and look in a matter of 12 months. This is what we get. We go from this anterior rotation, from a posterior rotation to an anterior rotation. Look at the second molar. The molar finds its place in the arch. Look at the second molar finding its place. And of course, basal bone is being created under the apex of the second molar. This is a selection of profiles of patients that came to our practice. We do the best job in the world. Parents come in and ask us to treat what is dearest to their heart, and it is our duty, it is our responsibility to make those children more beautiful at the end of our treatments. Of course, when you purchase a washing machine, you get an instruction booklet, so do not use a PUL device if you do not read the instruction book, and do give the instructions to your patients. And so it just explains, well, the device is going to be a bit cumbersome in the first days. It's going to be difficult for you to speak and swallow, but it's just a matter of a few days. And then you explain to the patients as well that the tongue is going to maintain the device to the palate. We are obliged to provide such an instruction, because in case there's a claim, the judge is not going to call the PUL, is not going to call the device. The judge is going to call Dr. Callabe or Dr. Chams, because we are liable. We're not going to say, oh, the PUL device did that, the bracket did that. The device is not responsible for the treatment or lack thereof. We are responsible, we are liable for our treatments. And you have all this on the internet website, the instruction booklets, etc. This is a last case I would like to show. I know, I don't have much time, but this is very interesting. It is a Brody syndrome case. And when you want to treat a patient like this one, you really need a Swiss knife. This is our Swiss knife. So they wear the device. You need to know the instructions. After 9 months, we were able to get the red line. The red line is the maxilla, the blue line is the mandible. Look at this. I do invite you as well to have that delay software. If you want more quality in your result, do invest in this delay software. I do invite you, you young doctors out there, do use that. And this is how we could treat that very complex Brody case. Oh, a last case before I wrap up. Look at this class 3, agenesis of 12 and 22. What can we do here? Do we send her to the oral surgeon? Le full one? Implants? No, I have a Swiss knife. The tongue is going to be well controlled. I'm going to visualize the bicuspids, and she's not going to need implants. Now, my delay software told me it's not a real class skeletal, a true skeletal class 3. It has functional origins, and that's the beauty of our software. So you see that we corrected that crossbite, we visualize, and that's the innovation in PUL 3. This is the same effect that you would have with an extra oral force, a delay extra oral force, plus the self-ligating bracket. So that young girl was hiding with all that hair, and then she does pull back her hair because she feels more confident. No surgery, no implant in 12 and 22. And look at the red line. The red line was behind the blue line. Now it's in the front of that line, which means that we had an advancement in the pre-maxilla. Look at her profile, and this is how we finished her case. Thank you, Ellie. Thank you, that was great. Thank you ever so much.
Et on a fini sans chirurgie, sans 2 implants 12-22. Et regardez, la ligne rouge du maxillaire était derrière la ligne bleue, et là, la ligne rouge est devant, c'est-à-dire on a eu une avancée du prémaxillaire. Et voilà comment ce profil de cette patiente s'est terminé comme ceci.
Merci,
Désolé,
merci. Super. Bon. Nous avons eu